So thanks to everyone for joining our Q&A session today. I'm Christie. I'm the Head of Patient Services at the PBC Foundation. And I'd like to welcome along Dr. Alan Bonder, who's with us today as well, all the way from Boston. Thank you so much for taking the time to join us today. Do you want to tell our viewers a wee bit about yourself, Dr. Bonder?
Hi, Mel. I think everyone knows me for prior Q&As, but I'm Alan Bonder.
Good.
I'm in Boston, and I'm a liver doctor, and I do PBC and PBC research.
Brilliant, thank you. We're actually heading your way next month as well. So Robert's over in the US just now. He's delivering some self-care workshops starting in New York tomorrow and moving on to Chicago, San Francisco, Houston, Washington, and then our last sessions in Boston just ahead of ASLD starting as well. So we're really looking forward to that. So just to anyone in the US who might be watching us and joining today, just to say there's full information about those self-care workshops on our website. Please, if you think you would be able to come along, please have a look and register for that. It would be really lovely to see you there. So before we start our Q&A as well, I just want to remind everyone that these sessions don't take the place of a consultation with your own clinician. In these sessions, we aim to provide general medical information and not medical advice. Also, please just be mindful about Facebook being a public forum as well. If you want some more privacy, you can join us in the room here in Click Meeting, because the chat here in Click Meeting is not shared on Facebook. So I'll just get started with the questions that have been sent into us so far today, and then I'll keep an eye on the chat as well, just to see if we've got any live questions coming in. So our first question for today is, the background to it is the patient was diagnosed in 2005. They've had a consistent FibroScan score of 4.6. The previous one they'd had was 2 years ago. Their more recent one was 7.4. They've been told that's still in range, so it's okay, but it seems like a big jump for them and they're a bit concerned. So they just wanted a wee bit of advice on that and if they should be concerned about it.
So just reassuring that FibroScan results are low, and based on all the data that's out there, we know that people who stay with low FibroScans, I would say less than 7 or 8, they have really good prognosis. So I think it's we make sure that we look at the FibroScans, we look at the liver test, the alkaline phosphatase, the bilirubin. If all those things happening within normal range, that person has no issues and should not worry about anything that's going to happen in the near future.
That's great, thank you. Our next question, the background is a diagnosis of probable PBC in March this year, following 18 months of consistently raised ALP and GGT. They mentioned some other test there as well that's in the notes for you there, Doctor, around the negative AMA, negative PBC specific, and then some imaging tests that they've had. The symptoms that they're having is itch and fatigue. And the question is, does the normalisation of ALP and their other liver blood tests following 3 months of URSO from then confirm a diagnosis of PBC, or should a liver biopsy still be performed?
This is a great question. So we look at the current guidelines. I think the PBC Foundation does a pretty good job translating this as in kind of patient language.
We do, yeah.
We have 3 different kind of parts of the, 3 ways to that, 3 main issues that need to be accomplished so you can get diagnosed with PBC. Number 1, you have an elevated alkaline phosphatase. Number 2 is a positive anti-mitochondrial antibody, or AMA. And finally, if you have any of those 2, you have a diagnosis, but if you lack of one of them, then a liver biopsy is needed. I think with the symptoms is very suggestive. And again, with or normalization of the alk phos, it could be suggestive, but is not definite. So I think I would talk with that patient and that physician if that person will need a liver biopsy in the future. Now that the liver tests are normal, I'm not sure I will actually commit that person to a liver biopsy. But I think, I think it's very suggestive, but not completely confirmatory that the patient has primary biliary cholangitis.
Okay, thank you. The next question is around a patient who's been using antibiotics for a severe sinus infection that they've had for about a month, and they've developed some ulcers inside their lip. Their doctors told them that's because of the URSO in combination with penicillin. Just wanted some reassurance, is that correct? And if so, how could they prevent it?
I've never heard about ursodiol causing oral ulcers in combination with an antibiotic, so I would say there has to be something different. But again, in people with PBC who have ulcers in their mouth, for example, celiac disease comes to my mind. So there are other things that need to be ruled out before you blame on the medications and the ursodiol first.
I'm just putting a little note in the chat here in both places, just if there's any, we'll go through the questions that we have here that have come in, but if just there's any live questions as well, we can take them as well. That's great, thank you. Just moving on to the next question, there's quite a bit of background on this one around some history around their test results, and they're in the document that we sent to you, but just as a summary, they've got a positive AMA, GGT's high at 686, AST 66, ALT 79, ALP 121, 141, and they're not on any treatment. They've been told that PBC and the Sjogren's connective tissue disease are the primary cause of their sensory, correct me on my pronunciation of this, ataxia, myelopathy, dorsal column dysfunction. Is this a normal advanced side effect of PBC that's been left untreated? And if so, what would be the treatment, if any, to slow it from progressing?
I mean, that's a tough one. I would say that's something that needs more investigation. And with the data that was just provided, I'm not going to be able to comment on, kind of the diagnosis. But what I would say is PBC goes hand to hand with Sjogren's. Up to 30% of patients who have PBC have underlying Sjogren's syndrome symptoms, dry eyes, dry mouth. And again, Sjogren people have a positive ANA as well as patients with PBC. I think when you look at the liver test and all the symptoms, it sounds like it's part of it, but I will have to look in detail to make sure that we give a correct diagnosis.
Okay, thank you. I know it can be quite difficult when we get quite specific test results when you don't have the full history of the patient, so I appreciate that. So just moving on to our next question. Again, they've got some recent labs there that are showing their total cholesterol is 298. There's some other mention of some other scores there as well. They're asking if statins is recommended for PBC patients, and if so, is there a preferred one? If not, what other drugs are used to treat high cholesterol successfully in PBC patients?
Great question. So the first thing that we need to kind of understand is when you have what's called cholestasis, an elevated alk phos, our cholesterol levels go up. So what we see in patients with untreated PBC, their total cholesterol measurements are elevated. So we see their total cholesterol, their LDL, but also their good cholesterol, their ALGL up. And what we've seen is once we put them on treatment and they respond, we see the cholesterol levels coming down. But that doesn't, rule out completely that you might have underlying genetic predisposition to have high levels of cholesterol. And we do see that in a lot of patients. Or comorbidities. I don't know if the patient has diabetes or a history of heart attacks or strokes or high blood pressure or kidney disease. So I think we need to put everything in the same in the clinical context. If a patient has a lot of comorbidities, the use of a statin actually takes precedent over the liver. And there's been tons of studies saying that it is safe to use statins in patients with PBC with no fibrosis or no scarring, and then in fact with advanced fibrosis or scarring. There's a little bit of data. We need to be a little more careful in patients who have decompensated liver disease. So patients who have fluid in their belly, they're jaundiced, they're yellow in their eyes. So in those patients, we need to be a little bit careful with the dose of the statin. But I want to make sure, and then sending the message that use of statins is safe and it should be used in patients who really need them.
Great, thank you. We have a patient here who was diagnosed in January with PBC this year, and they're taking 1,000 milligrams per day of Urso. They're noting that they're saying their mother died of liver cancer in 1978 at age 47, and concerned that looking back, could she have had PBC, and that's not known. And what the question is PBC hereditary?
Yes, the answer to your question is absolutely. So there is studies that first-degree relatives, specifically females, have a 20% chance of getting PBC. So we do some type of genetic counseling in our clinic. So if you have a patient who's a female who just got diagnosed with PBC, we ask them if they have first-degree relative up and down, there are females, we ask them to, to make sure that when they are in the proper age, they should be checked for an antibody and liver test to make sure they don't have a diagnosis of PBC.
Thank you. That patient also asked a subsequent question just around a supplement, TUDCA, Tutka salt supplements, and asking if that would interfere with Urso. That was something I hadn't heard of before, so I'd had a little look to see what that was.
So my
And
advice is not to use any supplements. You know, we know that people who have underlying liver disease, if they get a supplement, they are at risk of having something called drug-induced liver injury, and that can put them in really a tough spot, and in some cases needing a liver transplant. So my advice is do not use any non-prescribed supplements because we really don't know what the people are really taking, and that could be a problem for the liver.
Okay. There's actually, moving on to the next questions, a similar one about a supplement as well. Is a patient who suffers from osteoarthritis with severe pain. They've been taking quite high doses of cocodamol for some time and just worried that that's not good for the liver. A friend has recommended taking turmeric. I'm presuming it's a similar response for that one, Doctor.
Yes. I mean, again, you guys in Europe have a little bit different. So what we know, there's being studies in the United States where they looked at people, what they take bottles of different supplements, and they analyzed the content, and 85% of the times, what you see that it's described in that bottle is not there. So I would say even because remember, it's not FDA regulated. So, you know, those supplements don't go regulation, same as medication. So my advice on everyone taking supplements, unless it's something that you was prescribed or is a vitamin that you really need, no one should take these, should be taking supplements.
Okay, thank you. Our next question is about fatigue. So we've got a patient who was diagnosed in January and is really suffering with fatigue, at times really severe. Is this normal of PBC or not? We know that fatigue is a really well-known symptom of PBC, but just asking around any tips that they can do around managing their fatigue.
So it is common. So up to half of the people diagnosed with PBC has some type of fatigue, and that can go from mild that, you know, you feel a little bit tired to some people not able to get out of bed. It's very, I would say it's a lot of burden. It really affects quality of life. And that's something that patients should talk to their physicians. And the next question is one of the tough ones. What can we do for fatigue? So the first thing we need to do as physicians is we need to make sure we rule out other causes of the fatigue. So we know that PBC goes along with other autoimmune conditions or other conditions. So we want to make sure that we exclude thyroid disease, which is one of the big ones. Other autoimmune things, Sjogren's, or, you know, some type of arthritis, lupus, or anything else. And then once we ruled out everything and we don't have a really good explanation, and we are blaming the fatigue on PBC, studies have shown that the best thing to do is exercise. And people are saying, well, you're crazy. I can barely get out of bed, so how am I going to be able to exercise? And we know that even 3 to 5 minutes, that's a start. And just get you moving. That's what really going to get you off of that cycle. So we encourage people to do any type of activity so that can, you know, increase their exercise. There is a lot of programs out there online. I've seen, for example, the PBC in Canada has a really nice, it's called the Empower, which basically have this type of, you know, help online, even help in person. So we'll encourage patients to try to reach out to those programs because they've been very successful in getting these patients their fatigue under control.
Yeah, and movement as medicine is something that the foundation very much promote as well. But I do appreciate what you're saying. You know, patients who have really severe fatigue, but getting outside for a little while, even if it's a short walk, just the benefits of getting outside as well, and taking a short walk can really help with that as well.
There's one thing, Mo, that we need to make sure we have to make sure that gets communicated to the patients, you know, because we do not have a really good treatment. That doesn't mean we don't need to ask about them. So again, has to be a kind of a both ways relationship. And I ask patients, you know, do you guys have any fatigue? And getting to, you know, communicate your symptoms to your patient, to your physicians is so important so we can try to get you treated. So I want to make sure we encourage everyone out there when they have symptoms, talk to them with your physicians. Don't be shy, because I know we are on a rush and trying to get your liver test better, your disease control better. But symptom burden is a big thing in PBC, and we need to make sure that we treat them because that can affect quality of life in a really bad way.
Yeah, no, absolutely. And that's something that we really encourage our patients to do, is prepare ahead of their medical appointments so that they are, and also tracking things like their itch or their fatigue as well, so that they've got some context around that when they're speaking to the doctor as well, so they can let them know and anything that they may have been trying to help with it as well. We have an app, the PBC Foundation have an app that we can use, that patients can use that to track their symptoms, and we've recently upgraded the website, but we're working on an upgrade for the app as well. and that will have some real improvements in how people can track and then go back and look at their fatigue score over the last month, 3 months, 6 months as well. So I think recording the symptoms is really useful as well, so that when you go to see your doctor, you've got a bit more information on that. Our self-care workshops do very much touch on the movement as medicine and the importance of getting out and sunshine and that type of thing as well. It's definitely something that's really important for us as well.
And one more thing that you touch, I think you touched like an important point. It is such a subjective thing, and making it objective sometimes is very hard. But again, using the help of the apps and scores will help your physicians understand how bad is the fatigue impacting your daily life. So again, that's so important to really discuss fatigue and itching with your physicians, because those two symptoms can really impact your quality of life. And again, I've had so many patients being shy about it because they're concerned. But if you talk with, your physicians, you might be able to get a plan, and that will be able to get you in the right track to get better.
Yeah, and that's what we would absolutely ask our patients to do, is to make sure they're sharing that. Personally, I had itch so bad that I had a transplant for that. So, and I had tried all the different treatments around itch. So I know how difficult it is to manage that day to day and the burden that it can have. And the change to my life that there was when I no longer itched, it was just amazing, So the burden can be massive. It can also have a really big impact on your mental health as well. And I think that's why the self-care sessions that we hold and the information that's on the website and the app is really important, just for patients to be able to empower themselves and try and take a bit more control in that, which is great. So moving on to our next question, we've got a patient who was diagnosed about 6 years ago with positive AMA and other liver function bloods. Weren't good at the time. The FibroScan's shown marked cirrhosis. They've been on urso, and within a couple of months, the cirrhosis has showed marked improvement, but they also have fatty liver, pre-diabetic, hypertension, and worsening kidney function. So quite a lot going on. They're looking at semaglutide medication and wondering how safe Ozempic is for use in PBC. They're asking if it's safe to have weight loss injections, and they've noted that they're over 24 stone and have stage 3 PBC. So really concerned about their weight and wondering what they can do best to try and improve that.
So this is a very interesting case, and I would say I'm going to divide my answers in kind of 3 parts. The first one is, we have the obesity epidemic out there, and we are seeing a lot of patients not only having PBC, but having metabolic associated fatty liver. We call it MASH, not NASH anymore. And that actually puts those patients at risk of progressing from no scarring to a lot of scarring and cirrhosis much faster. So, if we can modify those risk factors, if you get your diabetes under control, your overweight, your high blood pressure, that will make a huge impact on preventing your disease of progressing faster. So that's number one. Number 2 is semaglutide is what everyone looks like Ozempic. It's really, I would say, is the sexy medication out there right now. It's getting prescribed, I would say, like candies for all of us. And what we've seen, and it's safe to use in patients with liver disease. We use it, for example, in patients with compensated cirrhosis when they have a fatty liver. And what we've seen an impact in losing weight. So we see what the studies show, like a 12 to 14% weight reduction without actually needing surgery, which makes a huge impact. So what I'd say, this is what I've seen personally in my clinics. I have not seen any patient having any major issues using this when they have cirrhosis. We don't use that in patients with decompensated liver disease. Again, patients who have fluid in their belly, they're jaundiced. But personally, there's nothing out there. And again, when you look at the data and the scientific background, I don't think there is enough data now to show there is safety problems. But again, I think we're still looking and we're still collecting data to see what's going to happen in the future. We've only used Ozempic for quite a couple of years, so we don't have long-term data. We had data, for example, with a cousin of them, for example, another medication that's been used in the past with no problems. But again, if you ask me specifically as semaglutide is, we really have no scientific proof that actually is harmful right now, but again, is to be determined in the next couple of months or years. So that would be the answers to that question.
Thank you. Moving on to the next question, we've got a patient who hasn't had an alcoholic drink for over 2 years, as they're worried it'll affect their PBC. They've reacted very well to Urso, and last FibroScan was 4.6, so all in a good place there. But not going out and socialising and drinking has had an enormous effect on going out, and they're even on antidepressants and not feeling themselves. They're just asking if we can clarify what would be the maximum number of units that's safe, of alcohol units that's safe in PBC.
I mean, as a liver doctor, saying that drinking is actually okay is not one of the things you will listen from one of us. But I would say if this FibroScan is low and the liver numbers are normal, if you do a mild to moderate amount of alcohol, I think that should be fine. But again, that should not come from a liver physician. So I can't comment, and that's something that I would recommend doing.
Yeah, I had a look just to check in terms of what the UK guidelines were in terms of the recommended units for a week, and I think sticking within the NHS guidelines in terms of that, or the appropriate for if someone stays out with the UK. These are all the questions that we had that I'd sent on in advance to you. We've had a few more questions come in there since then, and we've also got a few questions coming in live on Facebook. So the next question is, the background to the patient is they were diagnosed in May this year and they're on Urso, but the last couple of months they're suffering really badly from heartburn and acid reflux. Is this a side effect of Urso or something to do with PBC, or completely unrelated? They've never had that problem before, and asking if it's okay to take Gaviscon to help with the acid reflux.
So answering the question, number one is, there is called the gastrointestinal distress of Urso as part of the side effects. I usually get more patients with bloating and kind of other constipation and diarrhea, but I don't see a lot of heartburn. So I would say it's not common as a side effect of Urso. Number two, yes, it's okay to use Gaviscon without any major issues. I want to make sure that your kidney function and the other things get checked before you're able to consume all those aluminum antacids. And finally, is I would just talk to the physician and see if you need to get an endoscopy. I don't know how long has that been going, what the age of the patient is, to make sure there is no ulcers or anything else underlying the esophagus that needs to be addressed. But this is not related to PBC and not related to Urso.
In case there's anything else going on. No, that's great, thank you. There's actually a question on Facebook, just when you mentioned bloating there, asking if PBC causes bloating.
So I would say no. The bloating can come as a problem from, underlying celiac disease. So again, if patients complain a lot of gastrointestinal bloating, I will rule out celiac disease or other gastrointestinal issues. If it comes with inflammatory bowel disease or other autoimmune conditions, but it's not related to PBC.
Okay, thank you. We have a patient who's been taking amitriptyline for several years, initially 10 milligrams and later increased to 20 milligrams. The question is it safe to use amitriptyline for pain relief rather than depression?
Yes, no problems.
No issues with that. That's great, thank you. I'm just looking through a few other questions that we'd had sent in there to see if there's anything else. We have got a couple of questions coming in live on Facebook. If you have any other question for us, please just pop them in the comments, either here in Click Meeting or on Facebook as well. So we have a patient who's asking about Urso and they're suffering hair loss, and if that's related and if there's anything they can do for that.
Again, this is not a common side effect. So again, things to rule out, for example, thyroid disease is one of the big ones. So make sure that they ask your physician to check your thyroid, because that can cause hair loss in patients with PBC.
That's a recurrent thing, isn't it? Is not to assume that something that's happening is related to the PBC, and just make sure that there isn't anything underlying that's going on in the background as well.
Right.
We've got a patient who's asking about liver cysts. They've got 2 liver cysts as well as PBC, and asking if that's normal, something that would happen as an overlap.
I mean, it depends on the type of liver cyst, but if they're simple cysts, I would say there's nothing to worry about. And, there's nothing to follow in imaging. There is no concerning of them becoming malignant. But again, I will have to know in detail more about those cysts, if they had any prior imaging or something like that, before I comment on the most likely scenario for the future.
Next question's around taking Urso, and they're asking if Urso can be taken, both are tablets of Urso at bedtime rather than one in the morning and one at night. I know that there are a lot of patients who've said they tolerate it a bit better if they take it in the full dose in the evening. Is that something that you would say was okay?
Yes, as long as you take your Urso every day, it doesn't matter. So for example, patients who are really busy and they don't want to take, 3 tablets a day, I said take it in the morning, take it in the evening. as long as you take it every day, it doesn't matter.
It doesn't matter when it's spaced out. I think that helps if you can fit it into your routine as well, isn't it? You're less likely to forget if it's in your routine somewhere and you're taking it all at the one time as well. A patient asking about severe diarrhea issues at the moment. They're seeing their gastro at the end of November. Is it safe to take loperamide, LOPERAMIDE?
It is safe. Again, for example, things that consider to be something that you need to address right away. If the person has taken antibiotics recently, I don't know, there's a concern of an infection of Clostridium difficile or C. diff, and that's something that will not take Imodium, but, otherwise I think should be safe without any major issues. But again, check with a primary care, check with a gastro before you take those type of medications to make sure they're not harmful.
Okay, thank you. I'm just reading through these questions here, two texts. So we have a patient who has elevated liver enzymes for 3 years, but only recently was checked for AMA. Positive 6 months ago, and they wanted it rechecked in case of a false positive. They've lost £100 and got rechecked last week and still AMA positive, but liver enzymes are normal. What steps would you take if they were a patient of yours?
That's a really, really good question. And you're going to get a lot of different answers. So we know that AMA is very specific to PBC. There's not other diseases that can give you a diagnosis. There's no other diseases that can give you a positive anti-mitochondrial antibody. And there's two schools of thoughts. One is great that the liver tests are normal because they could be the abnormal liver tests to begin with were related to fatty liver, but now you have a positive AMA. So you can either do two things. One is follow the liver test closely and the alk phos starts going up, then you start treating it as the patient had PBC, or the patient has maybe PBC and now you just treat them in urso and you just follow the liver test. Both answers are correct, and then you will get different answers based on where you are in the world. So in my practice, what I do, if that's a confirmed positive test, we know that there's studies that if you follow them over time and you don't treat them, they will develop symptoms in kind of like histologic findings, biopsy findings of PBC in the future. So I actually put them on urso, which is basically a benign medication. But sometimes patients says, I don't want to take that. I prefer if you follow me once a year with liver test, and then I will do that too. So there is no literally a really right or wrong answer. There's different ways to address that problem.
Great, thank you. We've got a patient, I'm not sure where the patient is based, but they're saying, why is it so hard to find a hepatologist? Every time they're trying to find one, they're always given the name of a gastroenterologist. I don't know where they're based, and I don't know where they're reaching out in terms of that. I know we have some patients here in the UK who have trouble reaching out to us to get an access to a specialist. I don't know if there's similar issues in your area.
I think it is a big concern. I think you're asking the right question. I don't know where the patient is. If they can comment on where are they located, then I can try to point them and to see what's the best thing they can do for that.
Yeah. That was a recent question, so hopefully they're still online with us. Just pop in the comments where you're from and we can pick that one back up for you. I've got a patient asking about fatigue. We touched on fatigue earlier, but just asking about how to tell the difference between how to tell the difference between fatigue from PBC and fatigue from depression.
That's a tough one, but again, I think blood test and excluding and symptoms of depression, and then unfortunately the fatigue of PBC can lead up into depression. So it's really hard to say or tease out at the end which one is causing what. So I would say, make sure that they exclude other causes of the fatigue. And then after that, try to see the moving is so important. And if not, try antidepressants because, that could also help some type of, fatigue.
The patient who I asked about for the gastro and the hepatologist, she is from New York.
New York City or upstate New York?
Local near, sorry, the comments are coming in thick and fast, and when they do that, the comments move for me. I'm just keeping track of them here. Local near, the name of the place that's just put in is SYRACUSE, Syracuse, New York.
Okay.
Or that could be, it's NY actually, so it's maybe not New York. It's
Yeah.
maybe.
So Syracuse in upstate New York. I mean,
Is it? Perfect. Thank you.
I mean, if I can try to find out some names for that person, and I'll try to look for them and online, and we can follow that later.
There's a question as well, just following on from that. And is it important to see a gastro as opposed to a hepatologist? And following on from that, what are the differences?
I mean, I would say PBC specific. I do think there is a big difference between seeing a gastro. Although I would say general gastroenterologists should be kind of comfortable managing, I would say 60-70% of the cases. So we know that 60-70% of the cases with PBC will respond to urso. And really, there's not a lot of need for a lot of extra, knowledge for that. But then those patients who, for example, have symptom burden or they not respond to therapy or the diagnosis is questionable, I think those patients will benefit more from a kind of liver specialist than a gastroenterologist.
Okay, because that had been the question. What do the gastro and the heps different terms bring to the conversation? But I think you've explained that, so thank you for that. That's appreciated.
And I think that patient, access isn't a problem. There's no liver doctors everywhere. I think we are located more, for example, big cities where we have transplant centers, but versus, gastroenterologists are kind of spread out through the entire country. So I would say it's a good place to start to look for a general gastroenterology, make sure that there's nothing severe, because it could be that with, just Ursodiol, you'll respond and you don't need anything. And you don't need to be coming to the big cities if you're far away. So that would be one of my, my advice.
Yeah, no, that's great. Thank you. We have a question around a folic acid deficiency, and is this related to PBC? They also have overlap AIH, and they eat a good normal diet. Is that something that's normal?
So the answer is no, but again, AIH, which is autoimmune hepatitis, that's what it stands for, can have treatments that interfere with folic acid. So, if there's any therapies that are doing that, then it's okay to take it. But it's not part of the general PBC patients to have folic acid deficiency.
Great, thank you. I'm just looking through our questions here to see if there's anything coming in. Any other questions for us here in the room as well? Please just pop them in the comments for us and I'll pick them up. So we've got a question from a patient who's saying there's a big debate whether ibuprofen or Tylenol are safe to take for minor aches and pains. What do you think?
Good question. I would say if patients have no underlying liver disease, for example, FibroScan is low, or they had a biopsy, doesn't have a lot of advanced fibrosis, I think using either Tylenol or Advil, it's okay for minor pains. Again, it depends on what the patient has. For example, someone with chronic kidney disease or diabetes and kidney disease, using Advil or those stuff puts you at risk of worsening kidney function, so I will try to avoid it. Also, patients with underlying liver disease, we avoid using Advil because that can cause us some type of bleeding in their stomach and kidney problems. So we just basically tell them to use Tylenol up to 2 grams a day. So it depends on the patient, but if the patient has no major comorbidities and there's no problems, I think either should be fine.
Great, thank you. We have a question coming in about what are thoughts on new therapies that have published phase 3 data? What does that mean for patients moving forward?
I would say the PBC world is very exciting. I think people heard that I would say there's close to 12, 15 new medications that will come out in the next 3 to 5 years. So if I were a PBC patient, I would say that if you wait 2 to 3 years, I think this disease will be under control completely and we'll be able to get everyone to normal. Right now we have one of the new medications, seladelpar, was just published, but, there is data with all the, elafibranor. So I would say it is a very exciting times in the PBC world because we are getting so many new medications out there. They will basically, I would say, cure the disease in the next couple of years.
That's amazing to think that that's possible, isn't it? So thinking about the trials for mainline therapies, but thinking about symptom burden as well, because we've touched on that earlier as to how important it is for day-to-day living for patients in terms of symptom burden. So seeing that there are some trials ongoing for fatigue and itch and things like that is really important as well. As I'd mentioned earlier, ultimately I went down the route of transplant for itch because there just wasn't anything else that was successful for me. I know there are lots of off-license treatments that people can try and they get some benefit from that. So it's good to know that there's stuff coming down the line for that as well, which is amazing, which is absolutely amazing.
But this is why it's so important, Mo, to talk to the physicians about your symptoms, because if we don't know them and we don't know they're being part of big burden, we really won't be able to look for those therapies. So again, we need patients who will be, who wants to enroll in those clinical trials so we can get those medications out there and they get them available for everyone. So that's also a very important message to send.
Yeah, and that's something that we've been playing a role in as well, and helping get involved in the clinical trials and patient recruitment as well. Something that if there's anything that we're aware of that's happening, we'll publicise that in our magazines. We'll get that in the website and information about that as well. It's something that we're really keen to be involved in as well. There's a question in the chat box in here, Doctor, that's quite a lengthy one. I just was wondering if I've got a question here in the Facebook chat, which is about the sessions we're holding in the US. So I'll respond to that just now. If you could read through that one that's in the chat in here for me, and then maybe summarize it for us, and then we'll take that one next, if that's okay. That's can you see it in the chat box here in Click Meeting?
I can. So I can go over it. So there's a person saying, how do I approach healthcare when my GI and PCP seems to be missing key treatments? I know the recommendation of FibroScan every 6 months, yet it's been a year since my last in the GI shows no intention of ordering one. So this is why I think is when, treatments are not working, which is 30 to 40%, this is a good time to start looking for a kind of another, like a more expert opinion, which is a liver doctor. As far as FibroScans, I think FibroScans there's no more data using it more than 1 to 2 years. So I do it in research every year. I do it in my clinical practice every other year. But unless there's major dramatic changes from 6 months, I think there's no need to do it that frequently. Then it says there has to be an underlying health condition that hasn't been figured out, the most likely unrelated to PBC. How do I get doctors to do more work and figure out what is wrong with me? Again, that will be depending what the symptoms are and what are the things that the patient complains. So I can't comment on that. And finally, it says a little history of my issues. I have been on URSA for 5 months and my numbers have not moved. I have chronic diarrhea, possible 3 years. 1 year ago, I was diagnosed with PBC, yellow hernia, IBS, ulcerative colitis, and a confirmation of celiac disease, or 15 years ago. I'm frustrated at the level of care, attention, feel helpless to make headway. First of all, I'm so sorry to hear that, and it must be really, really tough to get all those diagnoses and, living with that burden of all those symptoms. But let me just try to say, number one is, we call the people non-responsive to ursodiol, and this is what we have currently. Once they hit that magic number of 12 months, so after a year of not getting the right therapy, the right dose of ursodiol, they don't respond, then we start thinking about second-line therapy or clinical trials. In some patients, I don't wait up to a year. If I see that their numbers start going up, but their FibroScans are really high, I try to get them into second or third line therapies as soon as possible. But this is what we use in the clinical practice. And then, PBC goes with all the other things, ulcerative colitis and celiac disease. So I think the diarrhea needs to be assessed. Is this a celiac disease or this is ulcerative colitis or both? Or, maybe there's thyroid disease on top of the PBC. So I would just start maybe asking the physicians to look into this to make sure that there is nothing else happening. And again, I know the frustration is pretty high. I know that symptom burden is so high on that person, and I'm really sorry, but I think, we need to address and need to find out what's going on before I can tell them what's the best next treatment options.
Okay, thank you. I appreciate that. No, that was quite a detailed one there. We've had a patient asking here on Facebook just about the sessions that we're holding in the US in the next couple of weeks, and asking if there will be doctors and PBC experts speaking at the events. So there's a wee bit more information on our website about that, but the sessions are self-care sessions, so they focus on peer support for PBC and emotional, psychological and physical self-care as we live each day as patients with PBC. So they'll be hosted in the main by Robert, who will be there, and myself and Robert will be in the Boston session, the last one, just ahead of ASLD. So you will very much have a PBC expert with you to go over things at the sessions, which is great. And any medical questions that there may come in as well, we can feed them into these sessions for doctors. And there's also our helpline available for that as well, which is great. Just having a wee look here, we've got a question around asking, have you seen patients starting Oclavia and having severe itching and had to stop due to this? I'm aware that that can be a side effect of OCA.
Yes, the answer to the question is yes. So Oclavia is obeticholic acid. That's one of the second-line therapies that we have available. And there are 2 doses. There's a 5 milligrams and the 10 milligrams. And our goal is to get you to that 10 milligrams so we can try to get you to normal. If we've seen 50% of people on the 5 milligrams, up to 70% in the 10 milligrams, they have some type of itch. And I've had to stop patients those medications because of severe itching. The good thing about it is with the new compound, there's a compound of the bezafibrate and obeticholic acid. There is a clinical trial ongoing right now. The itch actually is so different and is not as severe as in the clinical trial that was described in the original one in 2016. So I think we are making a lot of progress in knowing how to treat itching in patients with these medications. So again, just sending the message that there is very exciting new medication compounds coming out, treating both symptoms and the disease together, and then hopefully we'll be able to cure PBC in the next couple of years.
I love that word, cure. I love hearing that word. Love it.
I would say cure, but I would say we'll be able to control that because, unfortunately, no one will be able to be undiagnosed with PBC. But at least, if you have it on remission, that's something that is as good as actually having a cure.
Yeah, we had the PBC Summit earlier this year, and there were a pharma company who was in, and cure was mentioned in the room many times around some work that's going on into autoimmune diseases in general, but PBC is the first one that's been focused on. And that for me as a patient, that'd been the first time the word cure had been used like that. I know what we're talking about today is more controlling the symptoms and controlling the condition, but in amongst all the other work that's going on, there is work going on looking at that type as well, which is just amazing.
But again, even from us, I'm happy to see those smiles. For example, Mo, you've been through a lot, and now you listen to this words, it's like, wow, this is so different. But like I say, 20 years ago, we will never think about, we were placing patients in the transplant list because we did not have medications to get them under control. Right now is we don't see a lot of patients with PBC in our transplant list because we have so many new medications that we're using, and then preventing them of being really having bad liver disease, needing a liver transplant. So there's a big difference in just a few years, or like 1 or 2 decades of this disease. And I think awareness is so important in education. I think this person is just saying, I've been taking my urso, my alk phos is not moving. Well, this is the time to start asking questions. How can I get to the next person so they can give me the right therapy? And I don't need to be really sick to be on the transplant list. So we need to make sure that people are not on the transplant list and they are on remission. And I think we are getting close to that. And again, also, look for clinical trials close to you. On the US clinicaltrials.gov is one of the ways to look for what clinical trials we have available. I don't know what the UK system looks like, but I think that's something will help us a lot to try to get those medications approved faster.
Yeah, there's a similar website for the UK as well. We've got a link to that on our website where people can check what's going on. But we do try, and anything connected with PBC for the symptoms or for mainline therapies, we try and promote as well, just to make sure that everybody's aware what's going on out there, which is, as you say, just amazing in terms of what's happening in the arena at the moment. We've got someone asking where you're located. So you'd mentioned that earlier, Dr. Bonder. So Dr. Bonder is in Boston. We've got a patient asking about itch, actually. Is there anything other than rivampicin to take for itching? They've tried rivampicin just to see if there's anything else that could be tried to help.
So the answer to the question is there are medications being used right now. For example, the fibrates. This is medications that we use to treat one part of the cholesterol. And they're being really great kind of getting the itch under control. There are medications specifically to treat the itch. They're right now on clinical trials called the IBAT inhibitors. But I can tell you, I don't know because, again, I'm part of the clinical trials. I don't know if the patient is taking it, but I had a patient within 24 hours said, my life was changed. I don't know if I'm taking a medication, so I don't know that. But that's really made a huge difference. And finally, all the new medications, seladelpar, elafibranor, bezafibrate, all those new medications that treat the disease are also really good treating the itching. So,
Seeing benefits in itch as well. Yeah.
so my message is there is a lot of new treatments available. I've used rifampin for almost 20 years and really helps for me a lot. Again, there is some, concerns and side effects of those medications that need to be monitored. But again, sending the message that we have plenty of things available and then plenty of things that we can do for this type of symptoms.
For itch, the other things that were tried for me were sertraline and naltrexone. Tried both of those, and also tried plasmapheresis for a while as well, which plasmapheresis really did help actually, but it just wasn't sustainable in terms of how often it would be needed to make it worthwhile.
Right.
And it didn't take the itch, it helped just take the edge off the itch a bit. But for me, when I was diagnosed, my transplant was 10 years ago. So as you were saying, so much happening in terms of what the change in the landscape now. So even just knowing that there are new things coming down the line for it is just amazing, because I just know how much of and speaking to other patients as well, how much of a burden it is in terms of quality of life. And as I mentioned earlier, it has such an impact on your mental health as well, if you're managing itch as well as fatigue as well. So there's, just for that patient, there's some more reference to the different types of treatment for itch on our website as well. So if you wanted to go and have a wee look for some more specific information on the medications that I mentioned there.
But I think, again, just the main thing about itching is I have a lot of patients who are very shy to really talk about the itch because the stigma of the problem, either contagious and infectious problem. So there's different scales, but again, it's very subjective. And I think Mo, you went through this, but for someone who an itch of 10 could be an itch of 1. So there is all different scales that we can use to make it a little bit more objective. But also, it's so important to discuss this with your physicians. Fatigue and itching are two very common symptoms with PBC, and they're really not discussed in clinic visits. And it's so important to address them because we can really give some treatments for those type of symptoms.
And you're absolutely right, there is a bit of embarrassment around itch. If you're out and you're itching, people can think, what's happening there. So it can be really, really difficult. And I think that's where it starts to overlap into mental health as well. So it can really have such a big impact. I'm just having a wee look, guys. If you have any other questions, we've got about 10 minutes left. So if you've got any other questions, please pop them in for me. And I'm just going to go back and just make sure that I didn't miss anything as we were chatting through there. There's another question about statins there. So a patient who's on a fibrate with a 3.2 cholesterol, GP thinks I should also take a low dose statin.
Awesome question. And I would say the problem with using fibrates and statins at the same time is you are an increased risk of something called RABD or muscle breakdown. So more of it, you have a little bit of kidney impairment, more you have any other comorbidities. So, in those patients, we start with a low dose. We make sure that we check those muscle enzymes. We make sure they don't have symptoms of muscle breakdown, and then we escalate the dose. But again, you need to be very careful about not causing any major issues with that medication kind of compound.
For that. Lovely, thank you. We have a question coming about managing fatigue. I know we touched on it earlier again, but just to say this patient saying any tips on managing fatigue, generally hits in the afternoon for them like a wall. And I think a lot of patients can recognise that as well, where in the morning energy can be a bit higher, but as the day goes on, then it goes a bit downhill. And I think just going back to what we discussed earlier around movement is medicine and the importance of being able to do a little bit of exercise. As we say, we're not saying going on a marathon or cycle, hundreds of miles on your bike. We're saying just get outside if you can. Although I'd have to say in the UK today, we've got a storm hitting us today. So it's really bad weather here today. But get outside even just for a bit of fresh air as well, which works wonders. But just get out for even a gentle walk if you can manage it.
And also just remember not, to exclude other causes, thyroid disease, anemia, or celiac disease can cause severe fatigue. So, make sure they ruled out everything else. I've seen, depends on the type of fatigue, we have what's called peripheral fatigue and central fatigue. Using this, different types of therapies. For example, antidepressive can help. So again, I think this takes me to the message that I've been sending most of the hour. Just make sure that this is discussed in your clinic visits. I have another question. Is there any concern when taking steroids with uracil, budesonide specifically? The answer is no. I have a lot of patients who have overlap syndrome. So that's the combination of a diagnosis of autoimmune hepatitis and PBC. And I use the two of them together, and they have no really major problems.
Great, thank you. We have a patient here who's had cirrhosis for 10 years. Their bilirubin's raised at 30. Medical opinion is divided as to whether I'm ready for transplant assessment. Quality of life is poor. Sleeping 20 out of 24 hours. Any advice on that?
I mean, I think that person needs a liver transplant, unfortunately, based on what the numbers that they just said. So again, make sure that they're seen in a transplant center wherever they are in the world, because unfortunately, that's someone that will need a liver transplant.
Thank you. And just to appreciate, we've touched on some really wide and different subjects today, but if there are any patients who have been listening in and are concerned at all, or any patients who have asked us questions and would like some more specific personal advice, please just call us on the helpline and we can take those and go through in a bit more detail. I appreciate when you get to the point where transplant is being considered, that can be quite worrying. So we're here for patients if they want to talk to us about that. Absolutely, anytime, just they can give us a call. We have a patient asking about a clinical trial that they've been asked to participate in from Capital Gastro. Is that something that you've heard of?
No, I don't know what Capital Gastro is. I mean, it's a group, I'm sure, but I don't know I don't know the group. I don't know anyone who works there.
It's not specifically ringing a bell for me. The patient asked that. If you wanted to email me and give some additional information, I'll look into that for you and see if there's anything we can do. There's a question about a link between PBC and high cholesterol. We did touch on that earlier. If you just wanted to mention a bit about that again.
Yes. So when you have an elevated alkaline phosphatase, and we call that in the medical world called cholestasis, is the way you absorb cholesterol. You need the bile acids go into your bowels so you can absorb all the greasy stuff and take it back to the liver. When either your bile ducts, or which is kind of like the ducts that can connect the liver and the intestines, or the intrahepatic, well, all the tiny bile ducts are affected within the liver, you're not able to kind of release those bile acids to reabsorb the cholesterol and metabolize it. So make sure you process it in a good way. So your cholesterol goes up, but your cholesterol goes up in total cholesterol, your bad cholesterol, and your good cholesterol. So we have a bad cholesterol called LDL and your good cholesterol called HDL. And there's a little more proteins there that go in there, but I would say bad and good go up. So when they looked at heart disease and PBC, is if you have no major comorbidities and you treat your PBC, you see that cholesterol level start coming down. So there is no concerns, and we see that actually very frequently. But we see now a lot of people with obesity, metabolic syndrome, diabetes, chronic kidney disease, hypertension, strokes, heart attacks. Those patients, if they have the cholesterol elevated, they need to be treated. So we advise starting a statin or a cholesterol medication, because we know that there's no heart, there really is not going to be any liver. So the heart always takes precedence. So make sure that you treat your comorbidities and your cholesterol, because that's going to help your kind of span of life for the next couple of years.
Great, thank you. Lots, just as a check for see if there's any other new questions come in, Doctor, just wanted to say that there is lots of thank yous coming in for you spending your time with us today, and that they really appreciate that, so thank you. I've got one last question that I'm going to take just now, and this will be our last one. So we've got a patient who's a PBC for 13 years and on Urso, unfortunately a non-responder. Itch has come back after 10 years and been prescribed cholestyramine, which is not helping. Any advice I can ask gastro consultant to prescribe me? We've kind of touched on that earlier. So depending on where the person's based, there is some information on our website around the different types of treatments that they could try. But I think, again, it's just the importance of discussing that with our doctor, isn't it?
Correct. And again, I think the PBC Foundation in the UK or all over the world, but again, we have also societies here or ASLD. You can actually locate physicians there based on your location close by, so you can really see a physician who's expert in PBC. But I just want to touch base, Mo, and send them messages today, a couple of messages. One, I think symptom burden is very important. Don't forget to talk to your doctors about your symptoms. I mean, there's different ways to do things. For example, for us, what we're doing is we send all these questionnaires in advance of patients coming to see us. So when their patients hit our doors, they've already been asked multiple times about the itch, the fatigue, the abdominal pain, all those recurrent symptoms of patients with PBC. So it's a way to kind of like make sure that patients get, remind about all the symptoms so they talk about it. So don't be shy. Again, some patients, for example, the itching they're not really shy to begin with physicians. Use this type of groups to share those symptoms, and that might be a way, that you get a way to kind of like communicate this type of symptom burden to your physicians. And finally, I just want to kind of share that we are very excited in the PBC world. It is such a good time to be a PBC physician, because we have so many new, really available treatments. Hopefully will be cure, get this disease under control. And then, as soon as we can get those clinical trials enrolled and get them out there, we will be able to provide those medications to the general population. So it's exciting. And again, people like Mo and the PBC foundations, the PBCers, PBC Canada that have interacted, doing an amazing job educating people, because it also takes a lot to educate our like nurse practitioners, primary care, general gastroenterologists to know about the disease and symptoms. So I think we're in good shape, and hopefully we'll have more stuff available for everyone very soon.
Yeah, no, it is very exciting. And just as well, in addition to talking to your doctors about your symptoms, there's also the option to ask about any clinical trials that are available that are ongoing in your area as well. If there's the opportunity for that. As I say, we try and make sure that anything that we're aware of or we're working with companies on, we'll make sure that's shared. But please see if there's anything available that you might be able to take part in as well. So thank you so much for your time, Dr. Bonda. That's been brilliant today. We have got through so many questions today, which is brilliant, because we had quite a lot that come in ahead of the session and lots that's in today. If I have missed any questions, I apologise, but I will make sure I will pick them up from our sessions here and note them for our next one, and they'll get picked up then. So thank you so much for your time. It was lovely to see you, and hopefully I'll meet you in person at ASLD as well next month, which would be nice.
All right, Mo, thank you so much for having me again, and I will see you guys soon.
Lovely. Take care. Thank you very much. Thank you. Bye.